Yes, hello, I'm Brendan Larder and I'm Scientific Chair of the RDI. The state of play with drug therapy and HIV infection is really divided in two parts. One in the developed world, the rich countries, and then the poorer countries, the countries with limited resources. In the resource-rich countries, there are a number of choices of first line, second line and third line drug combinations, and drug therapy works very well and controls the disease very well. In the resource limited settings, the story is slightly different in that are limited resources, limited numbers of drugs and drug combinations, and so it's harder to make a number of different choices for patients on an individual basis in those settings. In well-resourced countries, when treatment fails, the physician will usually order a resistance test and will use that test to determine whether the failure is due to drug resistance or perhaps the patient has not taken the drugs and so the virus would not be resistant but still be susceptible to the drugs that the patient was taking. The main limitations of the common resistance tests, the commonest being genotyping, really is the interpretation of that test. The test is quite complex. It requires understanding of the results and interpretation of the results, and that can be really quite challenging when the resistance patterns that are seen are complicated. So a typical resistance test with genotyping and rules-based interpretation would tell you that the virus was resistant to a particular drug and sensitive or susceptible to a particular drug. But it wouldn't say anything really about the drug combinations that the patient was taking and how they would respond to those combinations. In resource-limited settings, the number of drugs that are available for treatment tend to be limited, and so a physician may not be able to select probably the most optimum drug combination. There are a limited number of tests that can be carried out, and in fact it's very uncommon to have viral load tests, resistance tests, and even in some cases the CD4 test. Well, in resource-limited settings, unlike in resource-rich settings, therapy isn't really at all individualised. The drug combinations that are used to treat patients are predetermined, and if a patient fails, then there will be another predetermined drug combination which may not be optimum for the patient. The concept behind the RDI's approach is to use a large collection of patient therapy data to model the data and then use those models to predict the response of a patient to a combination of drugs on an individual basis. To date, the RDI has collected around 150,000 patients worth of data, which includes millions of viral loads and thousands and thousands of genotype measurements. The RDI uses the data to train models by feeding computer models with data all around the time when a patient fails treatment, and the data will be viral load data, genotype data in some cases, but not always. The drugs that the patient failed on, the drugs that the patient has taken in the past, and the subsequent response of that patient to a new set of drugs. The models that the RDI develops are tested with independent data sets that comprise data that haven't been used to actually develop the model, and the typical accuracy of the models is around 80%. We felt the RDI, when we first developed these models that use genotypes, that it would be quite interesting to try and develop models without the use of genotypes. and particularly for use in resource-limited settings. This has been the focus of efforts over the last few years, and now we have models that don't require a genotype and are almost as accurate as the models that use a genotype. The critical information that these models that don't require a genotype use are viral load, the drugs that the patient has previously been treated with, and the CD4 count at the time the patient fails treatment. When we've looked at the predictive accuracy of genotyping with rules-based interpretation using the same test data sets that we've used to assess our models, we find that typically the accuracy is 60 to 65%, whereas with the models the accuracy is up at around 80%. We found that because the data that comprise the database and then the modelling in the RDI system are derived from many different countries, around 40 different countries around the world, and thousands of clinics, that the models tend to be fairly generalisable for patients in different countries. We've focused recently on the generalisability of patients from countries such as the African subcontinent, and because we have a significant amount of data now from those countries that we've used for the modelling, we find that we can derive accurate results as well from patients from those regions. We've attempted to assess the utility of the models in a real clinical setting in a number of different countries, including Canada and Italy, in a prospective way. And what we found was that the use of the models changed the physician's choice of combinations that they use to treat the patient with in about a third of cases. The models are used as part of a system as the engine behind a system that we call TREPS. And TREPS is the system that the user can input the information from their patient and then receive an output from that, which is a prediction of the probability of the patient's viral load going below a certain threshold, which is usually 50 copies per mil. TREPS is a very flexible tool. We've made it that way on purpose, so the user can just receive an output from the system of a prediction of their own combination they say, for example, the physician is thinking of using, or it can give a prediction of many combinations based on looking at the whole system. And it can even give predictions based on the local cost of the drugs that the physician has already inputted into the system. So it's very flexible and very user-friendly. In settings where drugs are not available or are not affordable, the system has the flexibility to basically ignore those drugs. And also, for example, if a physician feels that a particular drug or drugs shouldn't be used for a particular patient, for example, because of toxicity, then they can also select a box to ignore that drug or drugs in the final outputs and prediction. We feel that HIV TREPS would be of most use in resource-limited settings where the range of available drugs are limited, and there simply isn't genotyping available because of affordability. The clinical situations where we feel that HIV TREPS would be most useful are where a patient has already failed drugs and there could be, or probably is, resistant virus present, and that may have complex resistance based on the drugs the patient has been treated with in the past. In these situations, the models are ideal for making predictions of drug combinations that are more likely or most likely to work for that individual patient. Potential benefits of using TREPs will be, of course, to try and firstly reduce the amount of failure in patients by choosing a more optimal combination of drugs. Those drugs may be more cost effective if the models are used in that way, and could possibly save on the number of drugs that are used and drug combinations in the future as well by preventing resistance or delaying resistance. In the future, I think that in low-income countries, treatment will probably become more individualized, but that's because there are large efforts underway at the moment to develop point-of-care diagnostics. So, for example, easier to use viral load and CD4 tests, right where the patient is and where the patient really needs that test. And really then the HIV TREPS model is an ideal partner for that individualization, because that can be used then as a kind of a high-end part of the test to then make a prediction of the actual drug combinations to which the patient would then benefit. When I look back on the work I've done in the HIV field, at the start of that, the virus was only just being discovered really as a retrovirus that was responsible for causing AIDS. I was involved with the development of the first antiretroviral drug, AZT, and all the highs and the lows of that development. The highs being it was the first drug that could be used to treat patients infected with HIV. Then the lows, when we found that quite quickly the virus became resistant to that drug. And subsequently, my work went on to demonstrate that really to combat this infection, multiple drugs would have to be used. And we worked out ways and the best kind of combinations to use based on drug resistance patterns, compatibility of drugs, and drugs that were targeting different parts of the virus replication cycle. And that field has really moved on to modern day now, if you like, where instead of a patient having availability of one drug that really didn't work very well for very long, going through the era of combinations where they were taking masses of pills per day, to taking one pill that contains 3 or 4 active ingredients per day, and can look forward to really quite a stable prognosis for many, many years. So really the field has changed enormously, and particularly now that we've been involved with using high-level computational maths to make predictions on how patients could be better treated. It really is quite amazing to reflect on what's happened in what's really has been a relatively short period of time.